Pierre was the first, he can claim to be the one that changed the nomenclature as far as the categories in vascular malformations. When he changed the condition that was prior to him called venous angioma and angioma. Turned out to be absolutely a misnomer, but it persisted for a while. So Pierre actually made his publication with Patrice Burroughs from the kids at the time in Toronto, and they wrote that up and they called it the development of venous anomalies, so-called venous angiomas, and they published it in 1986. And they highlighted the various types of DVAs that constituted the limits of variability of the transcerebral venous system. So let's look at that. So he can certainly claim to be responsible for the name change. That was worldwide quite readily accepted by everybody. So it deals with the concept of the transcerebral venous system. Venous system is mostly ignored, but it actually explains a lot of things that can happen, positive and negative. And it allows for the communication between the cortical and the deep venous system, as we already showed you, and may compensate for congenital and acquired venous disorders. So we're talking about the communications, the various types of communications between the deep and the superficial venous system, and the tributaries that are leading into these channels. So I'll show you already this case as a vascular challenge. Here you can see the internal cerebral vein, thalamus striate vein, and then this thing that is sticking forward. It's enhancing the CT. And the thing is basically the outreaching deep venous system to compensate for the absence of a superficial cortical venous system that was improperly, not completely matured, and it has resulted in the need for different drainage from the region into the deep venous system. And this Pierre called the development of venous anomalies. So you have a superficial system that reaches out through one of those transmedullary transcerebral veins with its own tributaries, and consequently, instead of draining just the cortex of the brain, we now drain this single channel drains all the way down to the deep venous territory that normally should be drained into the internal cerebral vein. So let's look at some examples. Venous drainage deep to superficial. So the deep superficial system, cortical system, is dominant. And this what it would look like. You would see the dominant cortical vein penetrating the brain substance and reaching out to the deeper structures to collect the blood in that location. You can see the same thing here. You can see the superficial prominent cortical transcerebral vein draining down, reaching out to collect the blood from the deep, what normally would have been the deep venous system, as you can see there. Another example where the deep to superficial, you can see the superficial system reaching out, coming down all the way to the ventricular level almost, and collecting the blood in the region. So this is just a switch from an absent or not developed deep venous system to a compensatory mechanism, which is the development of venous anomaly that drains the other way around. And it can be the deep venous dominance, it can be the opposite system. So we have here an angiogram showing the thalamus striate vein reaching out a little bit further than normally to be expected. Another example of a transcerebral vein reaching out towards the cortex of the brain and collecting the blood on the side down to the deep venous system. You can see this can be quite extensive, so sometimes it's an incredible situation. If you look at the cortical veins on the right hemisphere versus those on the left, there's 0 on the left, so the left hemisphere is entirely draining into this extensive developmental venous anomaly that drains towards the deep venous system. So it's a deep dominance in view view of the absence of the other. And this is what the angiogram would look like. You see a very poorly developed cortical venous system and a very dominant deep venous system that's collecting all the blood from the entire hemisphere. Another example, similar example, but on the other side. And as we said before, the SWI images are really going to be dramatic. You can see very nicely these transcerebral channels that are collecting the blood and bringing it towards the deep venous system. You have to look at these channels, the tunnel channels as shown on the mark, but in reality, this is different. Right? These are prominent VR spaces, so make sure that you don't call them venous channels. They are CSF spaces that are prominent, that can also be seen, and sometimes are confused with the appearance on the mark from DVA. The same phenomena can occur at the level of the posterior fossa, so you have a cortical vein collecting with the deep cerebellar tissues, and here's the other way around. We have a deep venous drainage from the veins and reaching out towards the superficial cortical area of the cerebellum. And again, same thing, you can see the normal cortical veins on the left cerebellum, and on the right side you see very poorly developed cortical veins, and you see a prominent deep venous system that is draining the entire hemisphere. And this is a case from Sorrento, a very beautiful case showing again no cortical veins over the cerebellum whatsoever. Everything is draining deep towards the deep venous system of the cerebellum. A beautiful picture of the DVA, bilateral DVA, and the posterior fossa. So as Pierre already emphasized very strongly, he felt that these DVAs should be ignored. They are not a disease, they are not associated with any clinical problems most of the time. But later on it turned out to be that this was not completely correct. And there were findings associated with these DVAs, both on imaging and also clinical. Initially we thought that any bleeding associated with a carcinoma was, and the DVA at the same time was always related to the carcinoma. But we've seen, and you will see in a moment, examples where actually the development of venous anomaly was symptomatic. But that impairs the experience and hadn't existed yet. So we looked, a lot of people have looked at and collected the DVAs. You can see the channel and the tributaries that were associated with changes on MRI imaging or CT imaging. And these signal changes are not super rare. Another example, CT, you can see the signal changes on CT, the density changes. On MRI, flare-related imaging, and on the contrast enhanced, you see the development of venous anomaly. So you have in the area, in the territory that the DVA is draining, there are signal changes in the CT and on the MR that the significance of which is not clear. Are these just scarring phenomena, gliotic phenomena? And the majority of them seem to be, the great majority seem to be asymptomatic and not of any relevance and should be ignored. Another example of an enhancing development of venous anomaly, the flavoids and the sagittal view, and the perilesional signal changes on the MRI, the flare imaging and other imaging changes. So this can occur, as I said before, mostly asymptomatic, but it has been seen more and more as more and more MRIs are done with more and more people. And you can see these signal changes here, the development of venous anomaly there, and in the region the signal changes. So the group, Tom Thompson in the United States, they looked at that, they collected 164 patients with DVAs, a total of DVAs 175, and they looked at how often they had MR changes. About 12, a little bit more than 12% of DVAs demonstrated these signal abnormalities. In his that experience, did not show any of them to be symptomatic, so it was just incidental finding of signal changes on MR in the territory of the DVA, 12%. But as it became, as the experience grew and as more and more people were investigated, this is a case from Alan Taylor, I think, and yes it is, and it showed a young woman which was symptomatic with progressive neurological symptoms, and on the MR you can see the contrast enhanced DVA type of appearance. You see the signal changes in the region, and this patient was clearly suffering from this condition, and was further investigated by Alan, and it showed that the territory of the DVA had very slowly flow, and eventually there was contrast sort of stagnation at the outlet of the main channels of the DVA, explaining why these changes were occurring. This was an upstream congestion, and eventually that may lead to venous infarction and hemorrhage, but going through the stages, and so you can see venous occlusive disease of whatever type, whether it's thrombosis, can certainly make these lesions symptomatic. Another example of a patient presenting with a partial occlusion of the draining channel. You see the signal change in the draining channel, on the T1 pre and after contrast, and you can see there is clot within that channel, no enhancement is visible. You see the tributaries, so clearly there is partial thrombosis of the outlet in this patient, and certainly that can be expected to result in venous ischemia, eventually venous hemorrhage. The case of INSUP, and you can see the patient came to emerge, 42-year-old female with seizures, young female patient with a new onset of seizures. You should think of venous ischemia right away and ask for any other factors that may be the reason. Here you can see this was interpreted as a focal hemorrhage, but in reality it's an extension of a single channel growing superficially, and it was, since it was a small thing, it was no treatment was given. But in the same day, a few hours later, the patient develops new symptoms, more symptoms, and you can see now we have signal changes occurring, enhancement in the configuration of multiple channels as we see with DVA, but nothing else. And so we waited. A contrast enhanced examination at this point in time showed a filling defect within the draining channel, although there was still a classification of the tributaries at that point in time. And so this is clearly evidence of a DVA with partial thrombosis. And if the diagnosis is not made, and treatment is not started to anticoagulate, you will see that there is progressive loss of tissue in the region, and you see the clot within the draining channel from this DVA. So slowly progressive venous infarction with clot draining DVA. So that's one aspect, is the clot, the distal outlet obstruction. Another angiographic findings that in the minority of patients with DVA may show is this kind of capillary blush. There's no early shunting here, so it's not a great AVM, and the draining vein looks really like a DVA type of thing, but there is this early blushing stuff without shunting, and that's certainly in one of the angiographic findings that one can encounter in a very small minority of patients with DVAs. Another example, similar type of angiographic capillary type of blush without shunting, no early draining veins, but on the late venous phase you see what looks to be a typical DVA draining that region. So just be aware of it, it's a possibility, this kind of variation. But then of course you get to the point where there is some early draining vein and there is some shunting to it. So what are we dealing with now? Is it variant of the DVA, or is it indeed a brain EVM that is draining into DVA? Is that a possibility? So it can become a little bit challenging. For sure, what you need to do is an MRI under these circumstances, because as you know, in true brain EVMs, you will see the brain parenchyma is missing at the level of the nidus. Well, in DVA, the parenchyma is certainly preserved in between these abnormal vascular channels. So please do an MRI and look carefully to see if you can see normal parenchyma between these abnormal vascular channels. And Pierre used to say that they can never bleed, and this is, of course, you should not say never, never. And so this is a patient with an DVA that didn't bleed, then the hematoma resolved, and the channel remained afterwards. And this was clearly an evidence of previous hemorrhage from the DVA. Another example, elderly person came in with an interventricular hemorrhage. Contrast enhanced CT shows the typical appearance of DVA tributaries and the deep venous drainage. You can see the tributaries and the draining channel, and this patient has bled. There's obviously nothing to be done. The angiogram shows this area of hyperemia and the drainage towards the venous system of the DVA. And you can see perhaps there is some narrowing in some of these locations. It's hard to be sure, but clearly nothing to be done. What to look for under these circumstances is a cause of the bleed, right? If you see that there is a micro AVM or an aneurysm or something in the middle of these abnormal vessels that are representing the DVA, then clearly those patients should be further investigated with selective angiography and perhaps embolization if possible. So the fact that the DVA is bleeding is super rare, and if you see that, you should look for something else that is associated that can be treated. The DVA by itself, we shouldn't remove or in any way interfere with its outcome. You can only make it worse. This same patient came back 2 years later, now with an even more significant interventricular hemorrhage. So again, the same condition was recognized. The angiogram in 2 years later, this is the initial one. Maybe there's some progressive narrowing of the outlet, maybe at the junction with the vein in the straight sinus region, there's some narrowing. So we can speculate whether this has created an upstream hemorrhage. Certainly there's nothing to be treated, unfortunately, for this patient. But like I said before, be very careful, do very high quality imaging, angiographic imaging with DSA to look if there's anything that should be treated that is responsible for the hemorrhagic complication. Young boy presented with headaches and dizziness. You can see dramatic changes involving the cerebellum with evidence of previous hemorrhage and some edema pattern. You can see on the sagittal and on the gradient echo there is evidence of previous hemorrhage is there. So we have peculiar something involving the right cerebellum. Contrast enhanced, it's wild looking, there's multiple abnormal vascular channels, seem to be more than one vein or a convergence of vein or multiple venous outlets. It's a little bit unclear what is going on. Angiogram is wild. You can see the abnormal vascular appearance in the region. No early draining vein, so it doesn't seem to be an arteriovenous malformation. It's just a wild-looking vasculopathy type of thing that has the appearance of a DVA, a diffuse type of DVA in that location. And you can see again the lateral view. You see the hypervascularity and the prominent draining veins, no early draining veins, but prominent draining veins, and then these very abnormal enlarged venous tails. And so since there was no obvious cause of the bleed, we didn't see an aneurysm or an underlying microAVM, we let him go, and he came back absolutely dead. And a few months later, there was another major hemorrhage in that location, and the pathological specimen showed exactly the same findings as we were suspecting of a developmental venous anomaly, with abnormal venous drainage pattern, a collection of blood throughout the cerebellum into the developmental venous anomaly. So there's some literature on this, on the patients that can be symptomatic and why they could become symptomatic, that I'm showing you here. Some of them were from Timo. But the bottom line is, the main thing is to look for an underlying cause in the presence of a DVA that has blood, what should ensure that there's nothing else there that's hidden in that in the angioarchitecture that could be responsible for the bleed and that could be targeted for treatment. Then we have this issue of the DVAs associated with cavernomas, and we all know about it. And in those days, in those early days with Pierre, the DVAs were obviously, we felt were asymptomatic, and whenever there was a bleed, it must have been the cavernoma that was bleeding. And of course, in the majority of cases, is in fact true. But you can see there is this coincidental existence of the developmental venous anomaly and the symptomatic cavernoma, in this case, that was operated upon and removed. So usually, if there are symptoms related to such a combination of findings, they are usually caused by the cavernoma. You see multiple cavernomas again, some signal changes, and then contrast enhanced pattern that very much looks like a DVA. So we have a combination of DVA and cavernomas in the region of venous disease. And Timo had a case, a very nice case, where he could show that in time, from 2007 to 2014, this little ditzel over there became larger and larger and more looking like a cavernoma. Well, on the contrast enhanced MR, you could see tributaries in the region and the appearance of a DVA. So we have the formation of a cavernoma in an underlying or pre-existing, perhaps, development of venous anomaly in the region. So suggesting that maybe one could be responsible for the other. Now, people have looked, and this is Walid Yukichi from the Mayo Clinic. They looked at the prevalence of DVAs and cavernomas. They had about almost 1,700 patients with DVAs. 7% of these had associated cavernomas. So it's not super common, but it is not totally rare either to have this combination of DVA and cavernomas. And they made the interpretation of the prevalence of DVA-associated cavernomas was strongly associated with increasing age. So they felt that in time there was a likelihood for these DVAs to create cavernomas, perhaps. And cavernomas associated with DVA, therefore, must be acquired lesions. I mean, there is some evidence to suggest when one can draw that conclusion from looking at this material that the DVA was first and the cavernoma came second in time. Other conditions that can be associated with DVAs are capillary telangiectasias. You can see typical classic capillary telangiectasia is a poorly marginated area of increased density or signal on in the upper brainstem pontine region. Classic location for a capillary lesion, should never be operated upon, should be recognized as such. And in this case, you can see some enhancement of the vascular structure leading to the and towards the capillary lesion representing the DVA. So we have a combination of a DVA and the capillary vascular malformation telangiectasia. Another example, see poorly defined increased density and signal changes on the CT and the MRI, and yet there is some channel enhancement on the way to that area, representing the almost certainly developmental venous anomaly in coexisting with the capillary telangiectasia in the region. And then people, including Timo, were started picking up on other additional findings in patients, especially when DVA patients came with seizures, that they had the DVA, but also had migration anomalies associated with the DVAs, as the linkage of the maturation of the brain and the vascular system is closely linked, and any abnormality in one of them may certainly induce an abnormality in the other one. So always be on the lookout for in this case, cortical dysplasia in the patient with some developmental venous anomaly in the region, or migration abnormalities. So it can, in a small percentage of patients, coexist. Another example of a DVA is cortical venous dysplasia, in showing this relationship. This was published by Timo. Okay, so we've talked a little bit about DVAs and associated conditions. Some other venous anomalies that we can discuss is sinus pedicrani. They are variation in the venous drainage representing a communication between the intra and extracranial venous vasculature. We have an extracranial varix draining intracranial venous blood. So we're going to look at that as an example. It's so here we see the superior septal sinus in two different patients. Here we see a small channel going through the bone, an emissary vessel, an emissary vein going to the scalp region, representing an alternative exit in patients with venous thrombosis in the superior septal sinus. And here we have a true communication between the superior septal sinus and the scalp region in patients with sinus pedicrani. Usually it's in the midline. Usually there is a bone defect that can be seen on the plain skull or on the CT scan, and usually you can see the abnormal and then an enlarged vessel in the region extending, the enhancement extending to the scalp region. You can see again how the superior septal sinus has an extension of the vascular pouch towards the bone, and obviously it can extend further out towards the subcutaneous tissues. Rarely are they off the midline, but they can occur. Again, you see an enhancing structure on the just off the midline. You can see it on the MRI as well. And when you inject the contrast into the structure, you see the communication occurring with the superior septal sinus. So always be very careful with this. If this thing is becoming a problem for the patient, and once the treatment done, then when you be very careful that you're dealing with a lesion that is not communicating, or you have to choose different embolic materials, because if you inject alcohol in this and the alcohol escapes in the superior septal sinus, you're going to have a big loss of your as the result. So typically these sinus pedicrani, if you ask the patient to bend forward, then they will fill up with blood, and then they stand up and they empty again into the draining venous structures that are available. You also have to remember that you can be unlucky, or a patient can be unlucky enough to have a developmental venous anomaly draining normal brain, draining frontal lobe brain into the superior septal sinus, and communicating with this sinus pericrani. So if you are unlucky enough to inject alcohol, let's say there, and spill it into the adjacent sinus and create an occlude by mistake the outlet of the DVA, you have a huge problem on your hand. Patients with, and we'll get to that in the second session this year, about proliferative angiopathy, they can also have venous drainage into these emissary veins and the subcutaneous scalp veins that become very, very prominent, as you can see on the clinical evaluation and on the angiographic imaging. So we have sinus pericrani associated with an intracranial abnormal vascular condition called proliferative angiopathy. So again, be careful. These veins are needed to drain the abnormal brain. So don't go and block them or try to surgically remove them, because you have again a major problem as far as the outcome is concerned. Patient with a relatively small, what seems to be a venous vascular malformation. We injected into the malformation. We saw usual runoff of the facial veins and scalp veins, but then we suddenly realized there was also a straight thing here, the straight thing being, of course, the superior sagittal sinus, and that changes everything. So now we have to be careful to make sure that we don't have penetration of the envelope material intracranially, but you can see intracranially there's lots and lots of venous anomalies, developmental venous anomalies in this patient. So venous disorders, as we said before, the veins, the endothelium, all arise from the same location. And if there's an early hit, then the vessels involved in the brain, as well as the facial region, can all be involved in the abnormal process of development of the veins. So in summary, DVA and sinus pericrani variations in the venous vascular anatomy. There are variations, most of them are asymptomatic, part of a spectrum of often associated with other venous malformative disorders, as I just showed you. They're vulnerable because of the unfavorable venous collateral flow anatomy. So the DVA represents already a compensation for the absence of draining veins the other way, away from the region, right? So if something happens to the DVA, there is no alternative anymore. There is no other way out for the blood to go. So the DVA is in risk, unfavorable, vulnerable situation as far as collateral flow is concerned. Management should always be directed towards preservation of the venous drainage. So DVAs, whenever they are symptomatic, try to preserve the veins and with anticoagulation, etc. And as I said before, if they bleed, if you're so unlucky as they cause bleeding, then you have to be very, very careful in evaluating this digital suppression and geography, the bed of the DVA, to make sure that there is not an underlying microAVM or other pathology that needs to be treated, that could be treated, and might repeat. Thank you. Questions?